Hi everyone, Michelle Lyons here from CelebrateNewlyEberty.com. I am delighted and honoured to have my friend and colleague, Dr. Susan Clinton, on today to share her wisdom and her expertise on a deep dive about breathing. Breathing, I think, is one of those very fundamental things that we take for granted. You know, we have to breathe 18 to 20,000 times a day. It happens whether or not we think about it. And like the American Lung Association tagline says, you know, if you can't breathe, nothing else matters. So Susan was the first person that I thought of when we were picking out these topics to delve a little bit deeper on. And I'm delighted she says yes. We're both busy ladies, so it took a little bit of back and forth before we finally got to sit down together. But here we are, and it all worked out. So it's with great pleasure that I'm going to ask Dr. Susan Clinton to introduce herself. Tell us a little bit about your background, Susan, and then we're going to jump in.
Okay, sounds wonderful. And Michelle is right. We did have a little bit of back and forth to get this going. I think at one point I even got ill, and so you can't get on a video when you can't talk.
No.
Which is kind of interesting that we're speaking about the airway today and what that means, because if you don't breathe, you certainly don't function. If you don't breathe, you don't live. I mean, it's the most primal thing that we do. Yeah. So let's see. I have been a physio for longer than I've been doing anything else in my life. I'm at that age where you can kind of look back and say you've been in your occupation longer than you've been, you know, sharing the world with other people. I grew up in Texas and went to the University of Texas and got my physical therapy degree back in the days when it was a Bachelor of Science or certificate program. As the profession emerged, I had to kind of change with it. So I got my master's at LSU as I entered academia at that point in time. And then I got my Doctor of Science degree at Andrews University. Along with my, I've completed my fellowship in orthopedic manual therapy. Wow. Somewhere in between there, I took the exams and through the APTA to be board certified for women's health and ortho. So that's kind of the academic path, and it's not atypical of people from my generation to have gone back to school a number of times. I think that's the interesting thing about it, the transition to DPT in this country, is that a lot of clinicians went back to school, which was great. You know, they if nothing else, they started looking at the literature again, and I think that's making a profound effect on us all across, at least the United States for sure, and I know across the world. Social media has made a huge impact on all of us across the world. That's how Michelle and I met.
Absolutely.
I feel like we're really, really good friends, and it's because we've had many conversations in social media and discussions of stuff and commonalities between colleagues. So it's an interesting journey. I started off as an acute care physical therapist and moved quickly into neuro rehab and spent a great deal of my early career in neuro rehab. Really traumatic brain injuries, stroke, anything that had to do with the central nervous system. And I was fascinated, completely fascinated by it. At some point in my life, I made a sharp turn and went into academia and became the director of a faculty practice in New Orleans. Wow. And it was quite a change. I was still seeing neuro patients, but I also had a whole slew of orthopedic patients walking through the door. And it was like, okay, this is going to be fun. And I quickly realized that every single one of them had a central nervous system. And all of those tips and tricks that we did in rehab really worked with an intact central nervous system. So it was like, oh, this is a lot of fun. So I've been kind of looking at people from a different angle for a very, very long time. I'm not a very, what I would call regional specific type of physical therapist. So when I entered into pelvic health, it was because Dr. Wall, who wrote the book on urogynecology, was actually at Louisiana State at that time and needed a physio. So he came walking into the clinic and said, I need somebody to treat these patients. And I was like, okay, I'm in. So I went and learned with him. And, he taught me what he knew. And then he said, now, figure it out. Here's a few articles. Started off with some stuff from Carrie Bow and, just the original kinds of things. And there weren't any courses or anything at that time. I just went to the library and, it's muscles and nervous system and figured it out.
Exactly. As our medical friend Sandy Hilton would say, it's just orthopedics in a cave.
Exactly, exactly. So it was, but I had to learn a lot about the urinary system and the GI system. And that was another one that kind of came on me. People always ask me, how did you get to like talk, know about this stuff? And it's like the patients walk in the door. All of a sudden I got this influx. A colorectal doctor found out about me and started sending everybody. And I'm like on the phone with her going, okay, tell me about your protocol. What is Imodium? What are you trying to do? Why are you trying to do this? What are you thinking of when you have fecal incontinence? What is it you want me to do? Sure. I need to understand kind of from your perspective what you're going for. That's how I learned. It was like, okay, let's give this a whirl and see. Yeah. And
it's a very interesting combination though, Susan, because you've got neurology, orthopedics, and pelvic health. Mm-hmm. And of course, it's a fantastic way, I think, to get where you are now, because I think sometimes if practitioners go straight into pelvic health, they can become a little bit vagina-centric, and they forget that there is actually a body and a brain attached to that pelvis as well.
Right.
So I think it's fantastic that you can bring all those different perspective and lenses with which to view the whole person who's standing in front of you.
Mm-hmm.
Yeah.
Thanks. Yeah. So a lot of people will say, how do you get from A to Z? And it's like, get to work. Your patients will teach you everything you need to know. I know that sounds kind of like a trite statement, and I hate that, but it really is the truth. It's, patient care is what, keeps me authentic and makes me have to kind of challenge my confirmational biases all the time. It's like, I think I'm onto something, and then I go in and I'll go, nope, gotta think this one through a little bit differently. This isn't matching the thing. And the other thing is that I guess if you get kind of good at what you do, you're never going to really have the simple patients. They're always going to be the little bit more challenging ones.
The interesting ones.
Fun too. Yeah. Which is also fun too. So I'm happy with that. Anyway, so I've always been kind of messing with the central nervous system, and when I chose to go through the fellowship for manual therapy, one of the reasons that I did that was because of my introduction to a couple of gentlemen, Jim Meadows and Earl Petman. And they are integrative neurological therapists from the beginning. They were the first ones that were jumping up and down and saying, joint manipulation has nothing to do with the joint and has everything to do with neurological changes and muscle guarding. And, I just bought right into both of them, and I loved their stuff. And Earl was my mentor through my fellowship. And that's where I learned as much as I could about the trigeminal system and especially the trigeminal system from him. And, and I kept relating this in every class. It was like, well, what about pelvic pain? And what are we doing about that? And how, and he was like, just
absolutely
take the step, Susan, and just go run with it. I don't care what you do with it, but just do it. So I did, and I thought, okay, because it made so much sense. When we talk about that here in a few minutes, it'll make sense to all of you too, how you can recognize when you're getting into a full-blown central sensitization type process. There's some real clues and signs and symptoms that this is really coming on, and can help you redirect maybe what you're doing and jump out of the regional approach and maybe into much more of a, kind of taking a look at the body in a different way. Yeah,
absolutely. Well, that might be a good place to jump off on then, because I had a couple of key questions that I wanted to ask you and to pick your brains about. But let's jump in and talk about that vagal trigeminal alarm system.
Sure.
I love what you said about the perspective on manual therapy, because that must have been revolutionary at the time. But now, of course, we're recognizing that manual therapy works, but maybe not for the reasons that we always thought it worked. We're not really stretching fascia. This is what we're affecting. Novel sensory input, different motor output. So it's all
changes. Yep. All of those types of different things.
So tell us about this vagal trigeminal system. Where is it? What does it do? And what happens when it's not happy?
Yeah, sure. So if you consider the two systems, thinking about the trigeminal system, most of the neurological fibers and connections are all up into the cranium, except for the spinal nucleus of the trigeminal nerve, which actually reaches down to about C3 in the spinal cord.
Okay.
The vagus system actually originates up in the the brainstem, but has far-reaching effects down into the nasopharyngeal, into the thoracic cavity and cage, and down into the beginning of its interaction with the enteric nervous system at the stomach. And that's where it really begins to join and blend, and with the enteric nervous system, which of course is the entire neurological system for the gut. So you have that kind of connection, and it's like, how does that, why do we call it trigeminal vagal alarm, or why does Susan call it that? I think I kind of, pegged that term. There's always been a trigeminal alarm system, and that's part of the, the things that happen when we're under threat. We do have a trigeminal response that goes off. If you think about the trigeminal system, it affects the, it's the entire sensory response system for all of the cranial nerves. Yeah. So but it's got main pieces that affect the jaw and the tongue, motorically, it interacts with the facial nerve, but it's got a lot of sensory pieces to the facial nerve. And then there's the whole eyes and balance piece of it that goes along as well. And the whole system is designed to make us twitchy, so that we are alert. We're aware of our environment. We're able to sensory take everything from the environment in as, is this a threat or not a threat? And if it is, how do I respond to this threat? Sure. And, how we respond is really, quite different from person to person, event to event, society to society, and what has been culturalized as normal, for you as a human. And, so 300,000 years ago, I think they think Lucy is 3 million years old. So we've been on this earth a lot longer than we thought. We have these old brains that are, a lot of people call them reptilian. I don't like that word because I don't like thinking of a reptile in my head. I call it old brain because we just, it's the old, that old brain that hangs out with all of us, tends to still kind of work in the same way. And so as we're exposed to threats along our lifespan, we learn patterns, we learn response patterns, and those are given to us sometimes we develop our own response patterns, but they're very complex. And so over time, as we're exposed to threats, whether they're a high threat or a low threat, oftentimes we have a similar response. The pattern that we respond in is the same, and that's the way the central nervous system works. Is it sets things down in patterns so that it doesn't have to work so hard all the time. It wants to be as efficient as possible. Sure. So oftentimes we may have a fear about something and have a full-blown trigeminal response because it may be something that has been set up in our system to be learned that way. And it could have come from something really, crazy, like a bad experience in a dental chair. Could set you up for a trigeminal response down the road for every time you get afraid of some sort of medical procedure. Okay. So for women with pelvic pain, they hear all these scary words. They hear endometriosis, they hear, cancer, they hear, all of these things and all of these tests, and we have to run all of these tests. And, so that kind of gets that system on fire a little bit, and rightly so. They need to pay attention, put their feet on the ground. They're talking about, self-protection, survival, issues here. But for 30% of the population, it tends to persist. Okay. Why? We don't know. We do know what brains look like and that have persistent pain, and we know what brains look like that don't, but we don't know what the connection is, why this population over here is more vulnerable and will go into, persistent type pain situation versus the ones who won't. So some of it can be, so it's all complex. So this trigeminal system can be something that's running in the background. Okay. And when you know that you have a trigeminal system in trouble is when you're unable to turn it off. So I think all of us know that stress is a normal part of life.
As long as we're alive, there's always going to be stress.
Exactly. What's not normal is not being able to get out of it. Yeah. So maybe, and I think that socially and culturally, we're kind of predetermined to, especially as females, you can do it all. You're just going to do it all. Who's going to caretake? It's going to be us. Who's going to do it? It's going to be us. And so it's kind of almost like, I have to be more relevant with my things. I used to use Xena as kind of you have to be Xena.
I love Xena. No, Xena's cool. No, we're
okay, good. Because I was talking to a group of PT students today, and I'm like, you have no idea who Xena is, do you? But anyway, we're kind of meant to be Xenified. We're going to do all of these things, but nobody teaches us what to do when it's over. So we always hear those things. I'm great in a crisis.
Yeah.
And then at the end, we don't understand why they're sitting on the bed drooling 6 months later, because they haven't had any sort of, learned mediate response process to kind of bring themselves out of it. So we kind of stay in that heightened sense way too much all the time. And that's where that term living in the room with the tiger comes from, because it's kind of under a threat all the time.
And I think, Susan, what's interesting about the trigeminal system, I think particularly, are the diffuse type of symptoms that we can have, and oftentimes I've heard of people maybe being misdiagnosed with things like MS, because you can have visual symptoms, it can affect almost any part of whatever it interacts with. And I think that there's such a lack of awareness of this trigeminal system and how it can manifest everything from the airway to the olfactory to the visual, as I've said, to how you perceive noise.
Absolutely. So since it's a sensory aspect of all of the cranial nerves, you can have symptoms that people will kind of almost think in our society as crazy symptoms. So they're the symptoms of headaches that don't really follow a vascular pattern, retroorbital pain, fuzziness, the inability to focus with their eyes. Sometimes the hearing is really acute and they can't stand noise, or it feels like they've got a glass over their ear. So sounds become less distinguishable to them. Sometimes facial pain, muscle tics, in the face, and some jerkiness, and into the extremities just a little bit. Changing in taste. Sometimes they'll complain about, I have kind of a metallic taste in my mouth. And that's the big one, is the metallic taste that I think a lot of people will, relate to, and they worry about that and things they, they just, and they don't know why these symptoms are coming on. And most people will say, well, you're really stressed, or you just need to, get a dog, and and they kind of dismiss it. And what it is it's actually signs and symptoms that system has gone into overdrive. So it's no longer helping them be alert. It's actually dragging them down. It's becoming fatiguing at this point, because no one can maintain that sense of alertness for that.
No, you're just revving the engine all the time, aren't you? Burn out.
So it begins to tear us down. And so other things that start to happen when the trigeminal system is in overdrive is there's a lot of grinding, and there's sleep disorders. They're waking up in the night, and heart racing, arrhythmias are common with this, and certainly elevated heart rates. That's the big one Stephen Ford just really monitors. And this is where a lot of that heart rate variability studies are starting to crop out of. We're learning this, we're just scraping the surface on it, but they're learning that also heart rate needs to have variability, just like movement patterns. So it's very, very interesting. It shouldn't be this static kind of thing.
I think a lot of the symptoms that you're describing, though, sometimes, it's a handy excuse. Menopause, I think, often gets blamed for a lot of these symptoms. And I think, possibly what happens is, we push and push and push ourselves for so long, and then menopause comes along. And I just feel like it's your body just says, you know what, this isn't working for me.
Yeah, exactly. You got to find a new way to do this.
Put a pin in this for now, and we're just going to I'm going to force you to take a step back, and let's just reset the system.
Exactly.
How do we do that, Susan? How can we deal with that trigeminal system when it has become dysfunctional?
Right. So if you think about the elevated heart rate and probably even blood pressure, this may be a lot of the things that run behind what's oftentimes diagnosed as anxiety. And I'm not going to make arguments as to whether it's anxiety or not, if anxiety is mismatched. I think we all know what it feels like. And so, to me, the most efficacious thing that you can do for people is to get them to learn how to change their breath patterns and get some variability in their breath, so that they have some go-to instant things that are going to change their chemistry. So when you're in a state of a trigeminal alert or stress, you're more acidotic. That's, you're moving into a state of acidosis. That's what gives us that, ability to make rapid decisions in flight or fight. But we can't stay there. And so we need to learn how to pull ourselves out. So breathing is great. I love everything that everybody is doing about breathing. And, everybody goes, what do you think about this breath and that breath? And I think they're all good. Here's the deal. I think you need to do a variety of them.
Yes.
I don't want you to just be a belly breather.
It's a bit like posture.
I don't want you to just
there's no one good posture.
Right.
You need to be able to do them all.
Right. Right. I don't believe in good postures. I believe in that we get into patterns of dominant postures, and we need some variability and around that. But so the breathing, what I like to do is get people to, get quiet if they can. They have to kind of start in a, where we can really bring the senses down. As they get good at it, they can do it in the midst of noise. It's like learning how to meditate amongst chaos, right? So
build those muscles up a little bit first.
Yeah, in a comfortable position, paying attention to what's moving when you're breathing, and just feel it and understand that, gee, maybe I'm feeling a lot of breath up here, or maybe I'm really feeling a lot, or I'm clenching, or what's happening. And all I want them to do then is just change their breathing. I'll just have them put a hand on their belly and a hand on their chest, mainly just to bring their awareness to the whole area. But also self-touch brings us down.
Yeah.
There's a reason primates touch each other. Yeah. Because it's, we have
grounding, isn't it? Yeah.
We have neurotransmitters that respond with that, with the right types of happy juice when we, when you hold hands, when you touch, when you hug. So self-care is important. But mainly I have them put their hands on their belly and their chest, because I just want them to move towards something that they're doing, move towards something new than what they're doing.
Okay.
So if they're using their belly a lot, no judgment, I don't care. Or if they're using their chest a lot, what I want them to do is even it out.
Yeah.
So I'm just getting them to do something a little bit different, and that's easy to do because they can feel their hands move.
Yeah.
It takes their attention away from what the mechanics of breathing are, because people like to overthink that.
Wheels, up here that are spinning.
And they can just feel their hands move up and down, and I'll just tell them, even that out. That's your job, quietly for 5 minutes.
Yeah.
Even it out. They can do that laying on their side. They can do it laying on their back. They can do it.
And for most people, they have all the equipment that they need. They don't need to go out and buy the fancy biofeedback machines or the thermistors that are going to change temperature. It's just about putting people back into their own body again, and then giving them the tools to help themselves. So and I think that in itself is very calming. It's like, no, you can do this. You can do this. I'm not coming in to fight you. You've got this.
Right.
Yeah.
Well, it's turning the locus of control back to the patient.
Yes.
So that they're not dependent upon outside for help.
Absolutely.
And they've been caught in, many people with a lot of pain and problems have been caught in a system where they're being turned from one person to one person to one person. I want to turn it right back to them. Like, there are so many things you can do for yourself. We need these other healthcare providers for certain things, but not. This is something that can be, coached in and learned quite easily.
Absolutely. I do love a bit of confirmation bias.
Yeah. And breathing is one. I've been trying to get myself. I like to challenge my confirmation biases as much as I can. I can't get away from breathing, so it's just like I'm just all in with that.
Let's just keep breathing. It's working really well for us.
So when we begin to bring the trigeminal system down, it allows the vagal system to actually come up a little bit. So the vagal system gets dampened under a trigeminal alarm. And why? Because we don't need to be digesting our food when we're running from a tiger.
No, we need to get away.
Right? Right. But if we're in the middle of a crisis, we don't generally eat, do we? No. Right? You're not hungry. That system has been turned off and turned down.
Absolutely.
So over time, that system gets very, very, very sluggish. And that's where we get into, when you're in stress, you have a tendency to get towards constipation and things like that. And then when you lay down at night, you're not resting as well. So everything's not coming up. So if you can do some things to bring the trigeminal system down, rather than worrying about bringing the vagal system up, if you can turn the trigeminal down, you actually can that vagal system will start to return.
The vagus system, it's a very sensible system, isn't it? I mean, if you just get out of its way, it has a huge capacity to self-correct.
Exactly.
Yeah.
Exactly. It's absolutely amazing. And sometimes, though, it takes time. And the enteric nervous system is one that's slow to change lanes. So it takes some poking at it to get it to do that. As I always tell people with their colons and diet changes, it's like, you have to be in for a while. The colon is not going to change lanes quickly. It's one of the slowest transitioning organs we have. But once it does, it wants you there.
And it
doesn't want
loves
to go
habit.
back.
Yeah, it
Yeah.
loves habit
It's
and
like
routine, doesn't
took
it?
a long time for me
Yeah.
to get to be a stressed out colon. If I go back to this other way, I'm not going to like it if you take me back there again. So, so it's very interesting. So if we can, so I like to accentuate what we can turn down, because I think turning some things down is easier than turning other things up. I know there's a lot of things written about, oh, if you breathe this way, it'll make your vagal tone better. And it's like, oh, I don't know if we know that, but I do know that if we can make changes in blood pressure, changes in heart rate, changes in feelings of anxiety, changes in, just our ability to make decisions, changes in our ability to make good decisions by changing and bringing, the breathing into different variabilities. And that to me is like affecting the central nervous system in a very positive way.
Well, I
so
think
that
if we
actually,
yes. If we start stressing about the right way to breathe, it just becomes a whole counterproductive, aspect to it, doesn't it?
Right. I just want you to breathe different. Yeah. Just kind of like with movement. If it hurts when I move this way, then let's move differently.
Exactly.
Let's move in a way that doesn't hurt.
Exactly. So Susan, like following on from that then, because I think sometimes we think, well, breathing, yes, it's about getting the oxygen in and the CO2 out and just that gaseous exchange and energy. But if we're going to think, on this deeper level, certainly its role in optimizing trigeminal happiness, but also from a pressure management point of view, I love the work that you've been putting out about the role of the voice and the glottis as clues to what's really going on in terms of pressure management further down the system. Because again, the pelvic floor, nothing in the body works in isolation. And I think that's, I've been hearing that message from you consistently over the years that, yes, you've got a pelvic issue, but let's look at everything else that's going on too, whether it's nutrition or stress or breathing. But I think certainly in terms of pressure management, listening to how somebody is talking to you, what's their phonation like, what's the pitch of their voice like, can you change that? I just wonder, could you share your thoughts on pressure management and really looking at the role of the glottis with that?
I'd love to. So one of the most interesting things about voice production is that you have to have a functioning diaphragm. So your respiratory diaphragm has to be able to work, and it's got to have some motor control to it to regulate the airflow coming out, because that's what vibrates the vocal folds. And we all know that if we hold our breath, we increase our intra-abdominal pressure, right? That's why if you're going to lift at your 1 rep max, you have to breath hold. You have to breath hold, but if you're going to be working at 75% of your 1 rep max, you need to breathe. You shouldn't, breath holding for stability is when you really need to be all in, right?
Full on.
And not for getting out of a chair, not for getting out of bed, not for rolling around on the floor. We should be able to do normal human movements without having to hold our breath. But I think over time, we learn some breath holding techniques, either A, from pain, like back pain, or pelvic pain, or B, if we start to become incontinent. I don't know, it could be because maybe you had a baby and there was some vaginal tissue changes and your brain just never reintegrated the pelvic floor back into the system, but it doesn't like the fact that you're leaking. So it starts yelling at other muscles. It's like, do something, somebody do something. So the postural control system goes, I don't know, here, diaphragm, work harder. So we start kind of actually doing the opposite of what we should be doing, which is we start tensing everything up to try to stay continent, right? And I see this all the time with people. They come in and when they try to do a pelvic floor lift, they're just like, their face is distorted and they're holding their breath, and it's like, it's not that hard of work, but we've turned it into something very different because it's that whole thing, like we don't know how to get it back in. So we're just really overworking everything else to try to make that happen. When we run into, and that's a very, kind of thing that happens too with a lot of muscle guarding with pain. For whatever reasons we've gotten into pain or into persistent pain, we have muscles that are guarded. They're guarding, that's their job. They're like soldiers. They're being told to guard to the threat. And we have other muscles that are like, peace out. If you're going to work that hard, I'm certainly not going to come on. Not going to happen. So the interesting thing is when we start making all of these pressure changes through our lower pressure system from the respiratory down to the pelvic floor, and we have those issues of pain or incontinence or some of those things that are going on, we can really get a reflection of what's happening up into the upper airway.
Okay.
And one of the things that you can hear with people, just think about your patients who are in pain. What do they sound like?
Yeah, it's really
They're
tight. It's really, yeah.
It's tight, it's strained, it's sometimes higher pitched.
Yeah.
It's breathy, they can't sustain any type of, long conversation. There's a lot of that's going on, that you can hear in there. If it's somebody who has a very kind of low-toned, underactive pelvic floor, you start hearing not just the voice being lower, it is lower, but there's some really other things that are going on too. You hear a little bit more of what I call a craggly voice. I don't think that's a real word. Craggy, I think, is probably more the word. Whatever. To me, it's that crackly kind of,
Sure.
Sounds like you're coming off of a sickness. Like you had, a infection for a while.
Yeah.
And you're at the end of it, and it's just that last kind of, kind of stuff that goes on, and and they have a lot of throat clearing that they're doing too. And the reason for this is that system is not getting any kind of oomph from below. And so it's having to manifest it up higher. So we're working really hard through our upper chest to try to get, those accessory muscles are trying to work a little bit harder to help get some oomph, to get some air through the system so that they can communicate. So communication is a very primal thing too. Absolutely. We need to be able to do it, and we're judged and based on how we communicate. Yeah. We are. So if you can't get your words out, if you sound sick, people, people treat you different if they think you're sick. They're just kind of like, or back it off, But it's so they sound a little bit lower pitched. They sound like the edge of a sickness or coming off of a sickness. Sometimes there's a lot of throat, throat clearing. Every once in a while is fine. We need to clear our airway, but if it's chronic, there's something going on, and all of it. So the nasopharyngeal muscles all start overworking. So, and that's what makes
that forward head posture a little bit more, where the airways kinked a little bit. I mean, could that be a factor with it?
Actually, they do it in that they do the forward head and dropping the jaw in an effort to open the airway.
Oh, okay.
Because that goes back to the trigeminal and vagal system, because that takes you into panting.
Yes.
Which ramps your system up for your stress response.
Yeah.
So oftentimes they'll do that in an effort to, to try to get things out a little bit better.
Interesting.
So you can kind of, if you listen to people and listen to their voices and stuff, you can kind of get a clue into, But the coolest thing about that is that they hear their voice. They've normalized it.
Yes.
It's like watching your kids grow. When you watch your kids grow, you notice at the change of season that, you've outgrown all your pants. But your mother comes in and hasn't seen them for 6 months. They're like, oh my God, look how tall they are. Yeah, it's the same thing with our voice, is that we normalize it. We normalize what we're doing. We normalize incontinence. We normalize all that stuff. But if you can get people to pay attention to how they sound and teach them how to change it, that's a huge biofeedback for them to use.
Yes, yes.
Because they're not aware of breath holding, and they're not aware that if I can change my pitch, I might be able to actually automate and somehow start, recruiting the pelvic floor without having to think about doing it as a motor exercise. So it's great to teach people strengthening. It's great to do all that work Harry Bo does. I love it, because you need to have good, strong muscles. But
so you get people those muscles to change their voice. Do you get them to talk at a different pitch?
Yeah. Right. So if somebody is, and you can feel this on yourself when you do it, all you have to do is do a hum, and just feel your whole body when you do it. Bring that hum up an octave, or just go to a higher hum. If you don't do music, it's okay. And feel what happens. Your pelvic floor has to come up.
Wow.
To meet the stress of that requirement, of that task. And if you want to bring that pelvic floor down, bring your pitch down.
Wow.
Right? And it changes the vibration in the system. And all of a sudden so when I teach people to breathe and they're really ramped up, I'm going to use lower pitched hums.
Perfect.
If I need to get people to ramp up, I'm going to work with them into higher levels. So this is the most fun thing of all. with parents and grandparents and people. Here's my favorite ways to get people to work with their voice. When was the last time you actually sang out loud with the radio? What is your favorite song?
Probably. Well, I was singing some Patsy Cline badly in the shower this morning. Does that count?
That's badly or goodly doesn't matter. It's just the act of doing it, right? Because music has variability in it. Yeah. So you're going to get it, and I've had people say to me, well, what about rap? It doesn't really change much. Yes, it does. Have you listened to it lately? I mean, they're all up and down and making all those and doing all that crazy stuff. It's like perfect. If that's your thing, go for it. If it's not your thing, don't do it. The other thing is reading stories out loud. Okay. So if you have young people to read to, it's absolutely fabulous. Do all the voices. Oh. Do the little bitty pig and the little spiders and all the little things, and then the big bad wolf, and like all the crazy voices, because that's a way to really bring variability into our system. The other thing is that music and singing is primal. There's a reason we've been beating drums since we've been on the face of the earth. It brings us all together. So a lot of people who are in pain, it's not the pain, as David Butler says, it's the suffering. They tend to isolate. It's just all of these things. And then that feeds the system gets more stressed, because if we're not with our tribe, our chances of survival are not as high as if we are.
That's and I think particularly for women as well, because we have that more oxytocin-directed stress response, because if we're looking at things from an evolutionary perspective, if we didn't tend and befriend, that solidarity of a group of women together, we couldn't just pick up the groups of babies and run away. We needed each other to get by. So that's, I think, I've been reading some interesting studies how now we're seeing that social isolation is as much of a risk of death as smoking. So that's crazy, right? It's scary to think about it, but it makes sense, really. I know in my own community here in the middle of Ireland, there's a choir for older people, and it grew out of an active older group, and they come together once a week and they sing the old songs, and they get together for some camaraderie and some chat, and it's amazing to see how that has changed the dynamics of their lives. But I think as Christian Northrup even wrote a little bit about humming can improve your production of nitric oxide, which is a very important vasodilator. And all of these things are so elegant in their design, when you look at the neurophysiology behind them, but they're so simple to integrate into their lives.
They're crazy simple. And one of the things I tell people when I teach is, other physios, we'll be talking and doing some of this stuff. Yeah. And I'll, I say it over and over again, because I do professional coaching when I teach, to stop working so hard. You don't need to work as hard, and your clients don't need to work as hard. Everybody's working
smarter, not harder.
We're all working too hard. Have some more fun. Singing and laughing and changing voices with patients is fun.
We need to start a choir for physios, I think. Physio singing.
That would be great. That would be great. Although we'd have to like hire Ginger Garner or somebody to be
there. You go.
She's so good. There's no way I can compete with her voice, nor would I try. But again, it's not about being a great vocalist.
Yeah.
It's about just bringing in the jams that make you happy.
Enjoy
the things that make you happy. So one of the other things that I do with voice is people have trouble understanding oftentimes how to exhale with movement.
Yes.
And they're not aware that they're breath holding. They're just not aware of it. And they'll tell you I wasn't holding my breath, but you can tell that they're holding. We as physios can see it, right? We can see right away you're holding your breath. Don't do that. But I'll tell you, they can hear their voice.
Yes.
Their ear is right here next to their vocal cords. They can hear their voice.
Yes.
And so I use their voice when they're moving.
Oh, me too. Yeah.
Count out loud. If they're feeling silly, I ask them to name all the people in their family.
Fantastic.
I make them come up with stuff. Eventually, they come up with their own little stories to tell or something. But I'll just have them talk as they move, so they can hear what happens. Because when they're getting out of a chair, they may say, "Okay, I want you to count to 20." So they'll start counting 1, 2, 3, 4, 5, 6, 7. And it's like, did you hear that? Well, yes, I was struggling. It's like I want you to be able to get out of a chair and not have a sound, that voice change.
So you're using your glutes, not your glottis, to go from
exactly.
stand.
To get you up. Exactly. I love that. Use your glutes, not your glottis, to get you out of a chair.
I think that's what we'll call this episode.
That sounds great. I love it. So, but you can, so you're being able to do that is fantastic. And then when you think about it now, and you think about the idea that your diaphragm has to move and it can't get into breath holding when you're talking, doesn't that bring a lot more sense to why you should be able to, if you're out on a brisk walk with your mate, you should be able to talk?
Yeah.
That if you can't talk, you need to slow it down a little bit.
Exactly.
You
Well,
know,
those
so
guidelines are that you should be able to talk but not sing, you know, because you want to be working quite hard, you know, but not too hard. So I think, you know, it all.
So you're not going into breath holding early. You need to train yourself up. So you make him work hard, but the problem is that if you're not going to really gain a lot of endurance and stuff and performance changes, if you're constantly only working at the part where you're having to work so hard that you can't, you know, breathe. Your brain is just going to at some point say, if you can't breathe and do this at the same time, it's not going to be important for us.
Nope. We're out.
We're not running from the tiger here. Yeah. So that's where all of this high intensity, you know, interval training comes in, because it's a short period of time. You know, it's less than 15 minutes most of the time, but you're all in for that 15 minutes. The rest of the training is all about moving and strength building and breathing and being able to talk and do all of this stuff. So,
and now we're seeing some interesting research. You know, people like Chilemsky are saying, you know, and that's how you stimulate your neuroimmune system, by doing HIIT training, where you're up and then you're down, and then you're up and then you're down. Right. You have these built-in recovery periods, so your brain realizes that, you know what, yes, we're pushing hard, but it's okay, because we're going to have a little break, and then we're going to push hard again, and then we're going to have a little break. So it doesn't get freaked out, you know.
So and that teaches your older brain a new pattern of response to stress.
And that it's going to be
okay. It doesn't stay in its pattern of just getting wound up and staying wound up. It learns that it can come down. Exactly. And so when your brain has choices and variability, it can start you have a better richness of response.
Yeah, it doesn't automatically jump to the worst conclusion first.
Exactly.
You know?
You have to give it evidence to change.
Yes.
And reasons to change. And, you know, but if you can get those changes in, then you can have a much more richness to your motor system and to your response system, which is really important. So watch little kids move. They're constantly learning and challenging their system to build new and different patterns as they're growing and changing. But at some point, as we become young adults, the patterns start to set in.
Yeah.
And so older people, I would say that I would almost have to say, and it's something I'm kind of playing around with in my head, so I'll just throw it right out there and see what you think, that I think joint stiffness is as much of a direct result of neurological patterns as it is of chemical and whatever, you know, changes. That I think joint stiffness is way more complex than just the synovial fluid becoming a little bit more sticky and, you know, the cartilage wearing out. I think it's our patterns that we get into that begin to put us into a certain type of movement pattern that's so chronic and so dominant that that's what leads to joint stiffness over time.
I couldn't agree more. And, you know, I have a relative at the moment who has pretty advanced dementia, who's in, you know, a long-term facility, and, you know, sitting in a chair all the time, and you go in and you see kind of, you know, the nursing aides, oh no, he's terrible arthritis, that's why he's not moving. I go, no, I think it's because his brain isn't getting any stimulation, you know, because once, you know, I mean, no, you are going for a walk, you know, once he gets moving, not only the walking improves step by step, which if it was a fatigue or a joint problem, you'd expect it to get worse with more movement. The movement gets better, but the engagement with, you know, conversation gets better as well once he's moving, because his brain is like, oh, something new. What's going on, you know? And even in that case of advanced dementia, it's still there. It's still there.
Yeah.
You know?
Right. And it's very interesting because, you know, all of the studies on aging now are pointing to one of the best ways to, you know, keep a healthy brain is to move.
Yes.
So this is the thing though, because people don't like to move in the ways that they hear about on TV. Well, I always hear this, I should go to the gym, I should do this. It's like, I don't want to know what you should do. I want to know what you want to do.
What are you doing? Yeah. Yeah.
You know, you can go
watching the Food Network.
All this dancing and get as much yeah, ballroom dancing will give you much or more than the gym if that's what your jam is. You got to figure out what your jam is and then go do it.
Absolutely, 100%. So Susan, it would be remiss of me to not get you to talk just a little bit about bowel health, because I know that's your other passion.
Okay.
How does breathing tie in with good bowel health? Go.
Right. So if we're going to, if we're gonna dampen down the trigeminal system,
Yes.
which has really kind of basically told the vagal system to not work as hard, then we're definitely going to run into problems with not being able to have great bowel health.
Yeah.
And so this is where the situation gets just a little bit tricky. When I have people who are in pain, I usually don't like them chewing gum or chewing on the ends of their pencil, because that constant masticating kind of thing keeps things going.
Yeah.
However, when we get into a situation with bowel health, the breathing is wonderful because the diaphragm movement is the primary mover of the internal organs.
Absolutely.
Like, how many times did you say we have to breathe every day? I mean, so nothing's going to move the internal organs better than that. But if they're not getting a nice excursion and they're not getting great chest expansion, their lungs aren't filling up, and we're not moving the thoracic spine with breath,
Sure.
and we've got a system that's kind of, where it's just getting a little bit stagnant in there. Yeah. And, so movement, this is why when people are constipated, when the studies all will say that the best way to help somebody is to get them walking.
Yes.
Get them moving in different ways, because that stimulates all of that and gets it going better. But here's the thing. I think that, first of all, people need to learn how to let go a little bit. I think more
literally and metaphorically.
Exactly. I think that, exactly, from the other end too. But I think the issues with bowel health stem from the fact that the food that we eat, combined with the way we eat it, under the circumstances in which we eat it, and then the lack of sleep that we're getting.
Yes.
If we want to talk about breathing and all of that. So the breathing sets you up better for sleep at night. Any type of meditation, prayer, quiet time, reflection, whatever is your comfort zone and your, where you want to be deeply within your own self, are also another way to do it. We're not going to have great bowel health if we don't get good sleep. So the breathing really, not only, well, if you can get to where you're breathing well, that'll set you up for like sleeping a little bit better. And when you're sleeping a little bit better, you're going to have a little bit better bowel health. The other thing is that if your bowels are in not a good way, 95% of the serotonin that your brain needs for making good decisions is manufactured in the bowel. So the vagus system is binary. So when it's being clamped down on, things aren't going up as well as not coming down. So we have to kind of consider that too. So sometimes when I get into the thing about what you eat and what you drink, can make a huge difference in your bowel health, because you're not making good decisions about, it's just like, I'm just so hungry, I don't care, I'm just going to eat whatever I see in front of me, rather than taking the time to say, I need to really think this through, blah, blah, blah. I need to really kind of make sure I've got some good nourishing food on hand, or I know I'm coming up to a busy time. I've got to really double down and make sure that I was talking to my husband about that. I've got a real busy 6 weeks coming up, and I've already, I had to start last week planning, what am I going to do when I'm on the road?
Yeah.
And what am I going to be taking with me to eat, so that I make sure that I'm, doing the best things I possibly can.
You set yourself up for success.
Yeah, it's crazy circumstances, but I've been around the block a time or two, and I know when I don't do that, that it's not good. So, and I don't like the consequences afterwards, but we all learn by doing that. But getting just into breathing with bowel health, one of the other things that we can think about is when people, and we'll just talk about constipation, because that's the bigger one that I think.
Who doesn't love to talk about constipation?
Right, and it's like behind every urinary problem, there's a bowel problem.
Yes.
And I can say that probably 75% of people with GI dysfunction also have back pain.
Yep.
So it does walk hand in hand, whether one causes the other or not. They do walk side by side.
Absolutely.
And I think it's something to be considered. And faulty breathing is also a high contributor to chronic low back pain, much more than obesity or gender. Absolutely. So that's kind of really interesting. But when we think about,
if we're talking about women specifically, we know from Smith's study, don't we, that gut issues and breathing, much more so than obesity and BMI are linked to back pain in women. So you can't separate them out.
Right, and that was like on a study of like 15 or 17,000 women cross-matched for age and all kinds of stuff. It was a great study.
Yep.
So what do we do? How can we use breath to make bowel movements better? Right? So we can use breath and we can use voice.
Yes.
And, so a lot of people tend to hold their breath to create the intra-abdominal pressure, to overcome the intrarectal pressure, to get things to start moving down the pike. Yeah. And then, if we don't have enough intra-abdominal pressure to overcome the intrarectal pressure, we're going to fail from the top down. Now, the bottom part is you got to be able to, get the pelvic floor muscles to cooperate and go into a elongation phase rather than a shortening phase once the bowel movement enters the anal canal. So we can use a combination of breath and stuff to do that. So one of the things that you can do on the toilet to get people to start to increase their intra-abdominal pressure in a bit of a safer way than a full-blown Valsalva is to kind of pretend like they're either tooting through a horn or, short bursts, gaps of air, or they could just do a straight out, like, blowing up a balloon, like a.
I'm smiling because when I teach, this is exactly what I teach in my course as well. When we're talking about, you want to either growl, or you can moo, or you can hiss, or blow through a pretend. I mean, you can see above my head here, there's a lot of bowel, brain, bladder stuff going on in this neck of the woods. But I'm smiling because I think we're on completely the same page with
Absolutely.
it. So it's so I'm going to take that as more confirmation that I'm on the right path.
Yeah. So one of the things that I think that's important is this aperture here.
Yep.
Rather than.
Yes.
Because it's when you actually pucker the lips. Well, there's something very primal about it because that's the rooting that taps into the rooting reflex near the brainstem. You can kind of get into some brainstem stuff with that. But the other thing is that we know embryologically from our lips to our anus, we were one tube once upon a time. Yeah. And so when you do something like this, it actually can help you think about the stool coming out. Yeah. So it kind of changes the system a little bit. So they can do short bursts. They can do, like you talked about, putting your hand up. Sometimes, with kids, we hand them a kazoo. Because they like to make the noises, and it works. Adults are a little bit more like, I don't know if I want to play a kazoo, but that's where the humming comes in. Yeah. And what do I use for humming? I use a little higher pitch to get it going. Because we got to get the system going, right? We got to have enough pressure to overcome the rectal pressure, to get things going down the pipe. But as soon as they begin to feel it start to engage, they go down to a lower.
Beautiful.
So that makes sense, right? Because you don't want to stay at a higher pitch and bring your pelvic floor up, because that's not going to be good for pooping. But you may have to start there to get the feeling, some high pitched noises and some things like that. Yeah. Like you said, some humming or some, you can make high growly noises like growl, growl, like that, or whatever you want to do. And then as you get lower, then you can kind of bring it down, and you can just bring a variability in. And, people laugh when you do this with them, but that means that they're probably going to remember it and go home and do it.
Exactly.
And again, why not have some fun? We're talking about going to the bathroom, for goodness sakes. Yeah. We don't have to be so all in serious about it.
But apparently, Susan, people aren't like us. Normal people do not talk about this all the time, so I hear.
I know. So that's, if you want to engage people, do it with some voice stuff, because it'll really make them laugh. And when you get people laughing, then they're really not so stressed.
Exactly.
And that's always a good thing. But that's what I would do with the voice and the breath. With, when we're talking about good bowel health, you want to get people breathing in a variety of ways, because it's really good. Don't want them breathing way up here, or just in one, kind of dominant posture, or just with short breaths.
Yeah.
Good, nice breathing, finding that time to get their system to come down. But, really using that when you're actually in the mechanics of moving things through the system can be quite helpful.
Would it be fair to say that all the things that we've talked about today, from pressure management to trigeminal to bowel health, breathing is the answer, first of all, but also self-awareness and really using the breath as a tool to tune into what's going on. So that whole field of interoception versus proprioception, but breath is always with us, and it's such a valuable tool for just putting us back into our bodies again, and giving us not dominion over, but maybe more harmony with those processes that can spiral when we lose touch with ourselves, and when we slide down that stressful slope.
I would totally agree with that. Totally. I just, it's such an easy and such a primal thing for us to do.
Yes.
And, again, in the ABCs of CPR, what's the first thing? Establish the airway.
Okay, yeah.
Even when somebody is, on the brink of death, the first thing they do is make it possible for them to breathe as efficiently as possible.
Because if you can't breathe, nothing else matters.
That's right. So I think it's something that when we tap into in a mindful way, we can really make some wonderful changes that they really can learn to take it, and I've had many patients at the end of the therapy sessions that I've done with them, and this is always a tricky question to ask, is what did you get out of your therapy? Because be prepared for the answers. They may not be what you think they're going to be, but I would have to say that 9 times out of 10, most everybody will say to me, what I got the thing that did it for me the most was the breathing. Your emphasis on that and paying attention to it. And so
important.
So for my group, that seems to be, kind of one of the themes that resonates along the pathway with them.
Absolutely. Susan, where can people study with you, learn more about you? They definitely have to tune into your podcast that you do with Erica, because I think that's amazing. It's a fantastic resource. But tell us where people can connect with you.
Yeah, so my website is www.embody-pt.com, and my email is susan@embody-pt.com, and those are probably the 2 best ways to get in touch with me. Courses that are planned that I have links to and know about in advance are always up on the website, so there's some stuff coming up in the fall that's not up yet, but my spring and my early summer stuff is up. So I usually try to keep links up there so people can find out what I'm teaching and what I'm doing. And if you go to our website and sign up on my newsletter, the Embody newsletter, that's probably the best way to get information about what we're doing with the podcast mentoring and or courses that are happening.
And the podcast is Tough to Treat?
Tough to Treat, with my co-host Erica Mello.
Lovely.
From New York City, and myself, I'm in Pittsburgh right now. So we just get on the horn together and really just have a nice discussion about different clients or conglomeration of clients or things that we're running into that, to get each other's perspective, and we just kind of talk through it and have a good time with it.
That's really all we can ask for from life, isn't it?
That's right.
Susan, thank you so much. I mean, this has just been amazing.
Thank you.
As anticipated, I was very excited when we finally got a date in the book. So I want to thank you not only for sharing your brilliance with us today, but also for all that you do for our profession and for elevating us all, because I know you work really hard and you're always learning, you're always teaching, and you're putting it out there. And I think we all owe you a huge debt of gratitude as a profession. So on behalf of physios everywhere, thank you.
My pleasure. Thank you for having me on. This was fun.
My pleasure. We'll have to do it again.
Absolutely.
All right. Bye for now.